Our next presentation will be by the clinical pharmacist Reem Bahmaid. Dr. Reem, she is a specialized pharmacist at King Fahd Medical City. She has some scientific publications and she got awards for some hair studies research. And she will speak about perioperative management of anticoagulant therapy, bridging anticoagulation. Let's welcome Dr. Reem.
Assalamu alaikum. It's my pleasure to be a member of this committee. As the most common come up questions for a patient using oral anticoagulant undergoing elective procedure is what we have to do for their treatment. Do we have to continue or interrupt therapy? And do we have to give bridge therapy or not? So I will talk about the perioperative management of anticoagulant therapy for a patient undergoing elective procedure. I will illustrate on stratifying patient according to the risk factor of the thromboembolism if anticoagulant is stopped and the risk factor of bleeding. Also, we will review the current best practice in managing oral anticoagulant for a patient undergoing elective procedure, focusing on reviewing the guideline, HA and ACC, in addition to the CHEST guideline. Keep in mind that CHEST guideline many version and only perioperative chapters included in 2012. Also, we will review the result of the main data about this topic. Basically, more than 2.5 million people are currently using oral anticoagulant in the US, and oral anticoagulant considered one of the most common agent used among Saudi population, but we don't have the exact prevalence. Indeed, chronically anticoagulated patients are expected to become more prevalent as the condition is increased, and almost 10% of those patients underwent elective procedure. So the management of anticoagulation in patients undergoing surgical procedure is challenging, as interrupting anticoagulant will increase the risk of the thromboembolism. Surgery and invasive procedure usually associated with the bleeding, and this will lead to long time of the interrupting anticoagulant that lead to increase the risk of thrombosis. So interrupting anticoagulant is increase the risk of thrombosis, and continuing using anticoagulant for a patient underwent a procedure will increase the risk of bleeding. Both of these outcomes adversely affect morbidity and mortality for a patient. So the crucial approach for perioperative management of anticoagulant takes into account a balance between reducing risk of thrombosis and reducing risk of bleeding, along with the specific features for anticoagulant taking by patients. So there are some issues that we have to consider for a patient undergoing elective procedure using anticoagulant. We have to consider risk of bleeding and risk of thrombosis for a patient itself, and thromboembolism risk if we hold anticoagulant, bleeding risk associated with the procedure. The thromboembolism risk include disease-specific thromboembolism risk and hypercoagulopathy associated with the procedure itself, and the bleeding risk is only related to the type of procedure. The defined disease-specific thromboembolic risk is include patient diagnosed with the atrial fibrillation, patient have mechanical heart valve, and patient with the venous thromboembolism. And they categorize the patient to the high-risk bleeding risk patient, moderate risk, and low risk. So the risk of the arterial thrombosis for a high-risk group is almost 10% per year, and for venous thromboembolism is 10% per month. For the moderate risk group, risk of the arterial thrombosis is 4 to 10% per year, while venous thromboembolism is 4 to 10 per month. For a low thromboembolic risk group, risk of the arterial thrombosis is 4% per year, and for venous thromboembolism is 2% per month. So the risk of the venous thromboembolism is more higher than arterial thrombosis. Prohemostatic effect of the surgery itself also increases the risk of thrombosis, increase the risk of venous thromboembolism by 100-fold and arterial thrombosis by 10-fold. Not all surgeries require discontinuation of anticoagulant, as we have high procedure bleeding risk surgery and low procedure bleeding risk surgery. They define the high procedure bleeding risk surgery if the risk of bleeding within the first 2 days of the surgery is ranging from 2 to 4%, and if the risk is 0 to 2, is considered low procedure bleeding risk surgery. Also, there is some references define the high procedure bleeding risk surgery if the bleeding risk is more than 1.5, and if it's less than 1.5 is considered low procedure bleeding risk surgery. This is an inclusive list of the high and low procedure bleeding risk surgery. So in general, the perioperative rate of a bleeding is twofold higher than the rate of thrombosis, as shown in the published data that among atrial fibrillation patients underwent elective procedure, the risk of thrombosis is ranged from 0.2 to 2.7, while risk of bleeding is ranged from 0.9 to 6.3. And among patients diagnosed for venous thromboembolism, the risk of thrombosis ranges from 1 to 2, and risk of bleeding ranges from 1.2 to 3.5. And for a patient having mechanical heart valve, the risk of thrombosis ranges from 0 to 4, and bleeding from 0.5 to 7%. So as there is scarce in the data for assessing the risk of the bleeding and thrombosis for a patient undergoing elective surgery, the encounter question in the clinical practice is whether to continue or interrupt therapy, to bridge or not to bridge, and how to bridge. There is one meta-analysis published in the Circulation 2012. This meta-analysis done to assess both thromboembolism risk and bleeding for a patient underwent elective procedure chronically used anticoagulant. This meta-analysis consists of the 33 cohort retrospective study and only one randomized controlled trial. It includes more than 12,000 patients. And in this meta-analysis, they found that the bull incidence of the thromboembolic event is 0.6 among patients using bridge therapy versus 0.9 among patients not using bridge therapy. So it's not significantly difference between the two groups. And also they found that the overall bleeding is significantly higher among patients using bridge therapy compared to the other group. It occurred in 4.2 among bridging group versus 0.9 with the non-bridging group. The second study is published in 2016 is in JAMA. It's a retrospective cohort study done in 1,178 patients. This study done to describe the clinical relevant bleeding and recurrent venous thromboembolism for a patient chronically used or anticoagulant underwent elective procedure. And almost 60% of those patients using a warfarin for venous thromboembolism, and 79 of them considered to be at low risk of the venous thromboembolism recurrent. At 30 days, they found that the clinical relevant bleeding is occur in 2.7 among group receiving bridge therapy versus 0.2 among non-bridging group. And also they found no significant difference in the risk of thrombosis between the bridge and non-bridge group. Also, there is, in 2012, New England Journal published the result of the bridge trial. It's a randomized double-blind placebo-controlled trials to include 1,884 patients diagnosed with the atrial fibrillation using oral anticoagulant underwent elective procedure. And they found that the arterial thrombosis occur in 0.4 among no bridge group versus 0.3 with the bridge group, while the major bleeding is occur in 1.3 with the no bridge group versus 3.2 with the bridge group, with the significant difference between the two groups. So assessing risk of thromboembolism and bleeding for invasive procedure is less validated and only supported by some published data as mainly observational study. Accordingly, optimal management of anticoagulant patients remain controversial. And based on the quality of the published data, the international guideline provides recommendation with the low-grade evidence. The AHA-ACC guideline, they didn't give any recommendation for a patient underwent elective procedure and about the bridging therapy and discontinuation of anticoagulant. In the CHIS guideline, they recommend bridge therapy for a patient with the high disease-specific thromboembolism group, and for low risk, they recommend not to give bridge therapy, and for moderate risk, they either to give bridge therapy or not to give bridge therapy. You have to consider a risk of patient in addition to the type of the surgery. So if bridge therapy should be given and interruption for anticoagulant should be taken for the patient, the time of interrupting anticoagulant therapy must be carefully considered based on the anticipated length for sufficient lowering anticoagulant effect, and we mean by that the pharmacokinetic of the agent. So for a warfarin, they recommend to discontinue 5 days before surgery, and once the INR and the lower target level, we mean by that, too, you have to start bridge therapy if a patient included in the high-risk thromboembolism group or moderate. There is no standard bridging drug or dose, but they prefer to go with the low molecular weight heparin instead of the unfractionated heparin. As also the study showed that the risk of the thromboembolism is not significantly different between the prophylactic dose, low molecular weight heparin, and therapeutic dose, and risk of bleeding is significantly higher with the group using therapeutic dose. It's recommended to go with the prophylactic dose. So if low molecular weight heparin given before surgery, you have to consider stop this agent 24 hours before surgery. And if patient using therapeutic dose, consider to give half total daily dose, especially if patient underwent high-risk bleeding procedure. If unfractionated heparin used as a bridge therapy, hold this agent 4 to 6 hours before procedure if patient have normal renal function, and in case patient have renal impairment, you have to hold 12 to 24 hours before procedure. If fondaparinux is used as bridge therapy, hold this agent 36 to 48 hours before procedure. So also in chest guideline, it's mentioned that if patient underwent a dental procedure, they suggest continue warfarin with using oral prehemostatic agent or stop warfarin only 2 to 3 days before a dental procedure. So this flow chart can be used as a guide for a patient using warfarin underwent elective procedure. It's from older article, but still applicable. So if a patient have underwent low-risk bleeding procedure, no need to stop anticoagulant. And if high-risk bleeding procedure, stop anticoagulant, then you have to assess risk of thrombosis. If it's moderate or high, you have to use bridge therapy. Otherwise, no need to give bridge therapy. So this is for a warfarin. What about for the target-specific oral anticoagulant? Those agents have a rapid offset and onset of action, and this will obviate the need for perioperative management. Basically, for any patient using this agent, you have to consider two factors: the type of the procedure and the renal function of the patient. So if, in general, if a patient underwent low bleeding risk procedure, you have to hold this agent 2 to 3 drug half-life before surgery. And if underwent high-risk bleeding procedure, hold it 4 to 5 half-life before the surgery. So if patient using direct thrombin inhibitor with the normal or mild renal impairment, and they define renal impairment by creatinine clearance more than 50 ml per minute, underwent low bleeding risk procedure, hold the agent 24 hours before procedure. And if underwent high bleeding risk procedure, 48 to 72 hours before procedure. And if patient have renal impairment, underwent low bleeding risk procedure, hold it 48 to 72 hours. And if it's high bleeding risk procedure, 96 hours before procedure. For patient using one of the direct factor 10 antagonists with the normal kidney function 24 hours for low risk procedure, and for a high bleeding risk procedure, 48 to 72 hours. And if have renal impairment, 48 hours for low bleeding risk procedure, and 72 hours for high risk bleeding procedure. As most of the hospital labs, they didn't have the kit to measure drug level, we can use the coagulation parameter to anticipate the coagulation effect of this agent. So for a direct thrombin inhibitor, we can use ABTT and thrombin time. And for the factor 10 antagonist, we can use the BT and anti-factor 10. This also flowchart that can be used and help to assess the patient if using oral anticoagulant, target-specific oral anticoagulant underwent procedure. So when we have to reinitiate therapy after discontinuation, in a patient who receiving bridging therapy with a therapeutic dose, a low molecular weight heparin, and underwent high bleeding risk procedure and have high or moderate thromboembolism risk factor, you have to resume therapy 48 to 72 hours, either with a therapeutic dose or prophylactic dose based on the risk of the thromboembolism. And warfarin can be resumed 12 to 24 hours if patients have adequate hemostasis. So for the target-specific anticoagulant, if the patient underwent low bleeding risk procedure, you can resume it after 24 hours of procedure. And if patient underwent high bleeding risk procedure, 48 to 72 hours after procedure. And also there is some recommendation to start with the low dose instead of the high dose. So this is for a summary for the previous slides. For patients with the low thromboembolism risk, you didn't have to give bridge therapy. And for intermediate risk, you have to assess risk of bleeding. If low bleeding risk procedure, bridge the patient and start therapy 24 to 48 hours after procedure. If underwent high bleeding risk procedure, started therapy 48 to 72 hours post-procedure. If patients have high thromboembolism risk, underwent high bleeding risk procedure, this you have to consider started 48 to 72 hours, and if low bleeding risk procedure, 24 to 48 hours. So what about regional anesthesia? Is almost the same. For unfractionated heparin, wait 4 hours before removal or insertion of the catheter, and you can start infusion 1 hour after insertion or removal. For you patient using low maker wet heparin, prophylactic dose 12 hours before insertion or removal of the catheter, and for therapeutic dose 24 hours. And once catheter is placed, you can use unfractionated heparin with the 2 hours. For patients using fondaparinux as a prophylactic dose, 2.5, you have to wait 36 hours before insertion or removal of the catheter and restart fondaparinux injection 12 hours after catheter removal. So no fondaparinux while patient have epidural catheter. For a warfarin, you have to hold 4 to 5 days, and for the rivaroxaban, apixaban, insertion and removal should be 24 hours from the last dose of this agent, and you can resume treatment 4 to 6 hours after catheter is removed. So in conclusion, perioperative anticoagulation management requires balancing between the risk of thrombosis with the risk of the major hemorrhage. And the current guideline for perioperative anticoagulation management reflects the prevalence of the relatively high value on preventing thromboembolism and a relatively low value is placed on the preventing bleeding. In general, bleeding outcome is more common. Bleeding outcome is exceeds thromboembolism rate among patients using oral anticoagulant underwent elective procedure. And the decision-making process for perioperative management is challenging, especially in patients who have a moderate or high risk of thromboembolism and undergoing high bleeding risk procedure. For a patient with the low risk of thromboembolism, no need to give bridge therapy. So meanwhile, physicians should carefully consider both the need of interrupting oral anticoagulant for a patient undergoing procedure and the practice of routine bridging when anticoagulant is interrupted. And we have the decision-making guideline for KFMC for a patient underwent elective procedure. It includes all the type of the surgery and type of anticoagulant and also assessing the risk of thrombosis and bleeding. And thanks.